and the Director of Public Health for Blackburn with Darwin, is able to be with us, expert in this area. So Dominic, over to you, and about 8 minutes or so around COVID, its spread, how it spreads, and why it's more, the spread is greater in some groups than others. So Dominic, thanks very much.
Thanks, Peter. Well, I think probably most people on this call will know how the virus started in general terms and what the main causes of transmission are. I think you can't have avoided that over the last few months. Clearly, we've also got a new development now with new variants, particularly the South African variant, Brazilian variant, and the new variant that we invented here in the UK from Kent, which we know has increased the risks of transmission, particularly because it's more likely to be infectious, probably between 50 and 70% more likely to be infectious. You will hear some news within the next 24 hours probably that there is a mutation on those variants called E484K, and you'll have seen that that mutation has been identified in about 6 local authority areas. There will be an announcement at some point that it's spread further, and many locals will be taken and identify that mutation of the virus. The issue with that is that it carries the characteristics of the existing COVID virus, that it's more transmissible, but there is also a particular worry with that mutation that it might evade some of the vaccines. That's still under investigation. If it is proved to be an escaping variant, then it is possible to reformulate the vaccinations that we have to address that, but that will take some months. One of the possibilities is we would need those who've been vaccinated would get some protection, but we might need a second vaccination to cope with the new variant, a booster dose. So the coronavirus pandemic is a fast-moving pandemic with a number of different issues arising almost weekly that have to be responded to rapidly. And some of you will obviously be aware that across Lancashire, the directors of public health, the 3 directors of public health for Lancashire, asked faith communities of all denominations to consider, although they were allowed to by law, consider going online and avoiding communal prayer. The reason for that, of course, is that any social interaction at all increases the risk of transmission. That includes going shopping, it includes children at school, it includes anything you do from walking out of the house from your own bubble. With the best of intentions, you are going to increase your risks with every single social contact. And so I was saying earlier to Peter that I came across a quote from Martin Luther from 1527 when he was dealing with plagues in, well, he was giving advice actually to the civic and religious leaders in where was it? Wittgenstein or somewhere, someone might know. He was giving advice, and basically what he said was the advice for Christians was to help others as your first duty, but your second duty was to avoid going out, stay at home, because what you didn't want to do was to be responsible through your negligence for other people's infection and death. And that was 1527. And of course, the advice is broadly the same now for all of us. Any social interaction will increase risk, will increase infection, will increase mortality. So we do have evidence that, of course, Lancashire has been worst hit as an area. The Northwest has been worst hit than other areas. One of the ways we know who's been most affected is through not actually through the case data. Because if you remember, the first wave of the pandemic in the UK, during that first wave, really up until about May the 28th, we were unable to test everybody in the community who had symptoms. The only people that got tested were those who were hospitalized or were in a care home and then subsequently hospitalized. So if you were ill in that first wave, you simply self-isolated but couldn't get tested. Community testing only started from about the beginning of June. So the best way we know how many people have been infected is through antibody tests. And the Office of National Statistics do a random survey, a sample. And what that shows by region is that 5% of everybody in the southwest region, the least affected region, have now been exposed to COVID, have had COVID, and are now showing that they've got antibodies. But in the northwest region, that percentage is 15%. And in some of our communities, we know just from the case data, not from antibody testing at the local authority level, because we haven't got that data at that level. We've only got it at regional level. But we know, I know, for instance, that in Blackburn with Darwen, probably somewhere like 17 to 20% of our population will have been exposed. And in certain communities, in the Pakistani heritage community, for instance, we think that could be at least 25% of that population in Blackburn with Darwen, which is 15% of our total population, has already been exposed to COVID. On the upside, of course, they've now got natural immunity through antibodies, and we think natural immunity seems to be lasting about the same as immunized immunity, which is possibly good news. And so if we look at the pattern of infection in Lancashire, Blackburn with Darwen, for instance, had its first case on the 13th of March. Other areas of Lancashire had their first case slightly earlier, but Lancashire was a late adopter in the first wave. In the first wave, the virus really started in London, spread up north, and it spread out from metropolitan areas. So Manchester, for instance, had case rises earlier than we did. So Lancashire was a late adopter during the first phase. One of the consequences was we locked down then at an earlier stage in the pandemic, but we peaked later. London had already peaked by the time of the first lockdown. We peaked later during the lockdown, but it meant that we exited the lockdown, which was lifted at a national level when London rates were fine. We exited later with much higher rates of community infection, which meant that the embers which had already died down in London were still capable of being reignited in Lancashire, and they were. And Lancashire cases started to rise dramatically from the second lockdown, really started to rise worryingly from late July, and many areas in Lancashire then were in special measures throughout the middle to late summer and into the autumn, right up to now. And what we know from the case data is that if you think of one of the questions is who's had the most cases, so the cumulative case rate, Blackburn with Darwen, as an example, has had the second highest number of cases in the UK. Burnley has had the third highest. So we are carrying a burden.
Right, just 2 more minutes. Yeah.
Okay. What we know about the risk then is that it's unequal, the risk of COVID, the risk of being infected. And there are at least 7 factors which make it more likely you will have higher rates at a local authority area. And this, remember, these factors are structural, so they're beyond individual autonomy. They're to do with people's life circumstances, social and economic position. And those 7 factors are, first of all, low income. Low income communities have much higher rates of COVID spread and infection. And some of these are interrelated, of course. Low income families where the main breadwinner is in a frontline role and can't afford to self-isolate are much more likely to breach self-isolation and be exposed to the virus and expose others. We've got more smaller homes in Lancashire, and we've got more smaller homes with bigger families. And in the BAME community, we've got both of those things plus multi-generational families, which means that the most vulnerable are then exposed to a much greater extent than an average white nuclear family. We've got a bigger percentage of frontline workers in Lancashire. So if you went down to London during the lockdown, you'd see most of the professional and technical classes working at home. So London was nothing happening. Whereas in Lancashire, a much bigger percentage of the population out and about, risk exposed in food industry, transport industries, etc. So all of that on the basis of the first principle, the more social interaction you have, the more risk you have, is increasing our risk. And the last issue is that we have a higher percentage of BAME population in Lancashire and bits of West Yorkshire, of course, bits of North Manchester. All of those areas have had a higher transmission rate, and all of those communities have experienced higher transmission rates. What we know about ethnicity is there's no greater risk biologically from different ethnicities of either getting COVID or dying from it, but the risk is social and economic. So that is where we are. Where we are now is, just as a final comment, we've got rates coming down across Lancashire. Generally, there are some blips. If we have confirmed the new variant, we can expect perhaps that reduction to slow down, maybe even start up again. But generally the lockdown is having an effect here. The risk for us though is that the rates are coming down much slower in Lancashire than they are nationally. So as an example, Blackburn with Darwen at Christmas, when the London rates were at their peak because of the new variant, Blackburn with Darwen was 140th out of 350 local authorities. We've now dropped to 14th because the other areas across the country that had high rates over Christmas and the beginning of January have they've gone up quickly and come down quickly. We're likely to go up slowly, a bit later than the national average, come down more slowly and stay at a higher level. So that's our risk.
Great. Thanks very much for that great overview, Dominic, and highlighting the structural factors behind the transmission. So we're going to go into our breakout rooms now.
There was a very specific question, which was, is there any data around what activities cause the most transmission? So we were talking about, schools and shopping, and because obviously we're told any social contact, but it's kind of that sense of where are the highest risks? And that was the question that was asked.
Yeah. Sakthi, can you answer that? Can you field that one?
Of course, yes. And this is varied over the course of the pandemic. Largely speaking, there are 5 or 6 areas which keeps cropping up in the top 3, if you will, depending on the time. At the moment, it's health and care outbreaks, and shops and workplaces are the top 3 most common. It has been in the past, education settings, and then households is the main one. So those were the 4 or 5 places where, when you track back cases, which we do, but not in every case, it's called the common exposures analysis. So to understand where people might have got it from. So these tend to be the places, largely all indoor spaces, largely all, apart from the households, of course, where other people from other households come in. So those are common.
Thanks.
Peter, can I just add to that a
Very
comment?
briefly, Dominic.
Yeah. There's a bit of a paradox in that question, Susan, because Sakti's absolutely right. The way we think we know where people were infected is by looking at their mobility. Where were they? But of course, because you went shopping yesterday doesn't prove that it was shopping that gave you the virus. And that's the problem. What we know is that certainly in Blackburn with Darwin, I can speak about 50% of all the cases cluster in a single household. In other words, you get one case, probably an asymptomatic younger person who's showing no symptoms at all, so no one knows they're infected. Then you see, if you follow the dates of confirmed cases, you see 1, 2, 3, sometimes 4 other household members being infected. And 50% of all our cases are cases that are 1 plus 1 other in a single household. So where you get exposed, probably the majority of us are going to be exposed to the virus by another household member who was the index case, the first case in that household.
Yeah.
And of course, that's critical because we think that the risk is elsewhere, and in some ways it is, because of course that index case is being infected elsewhere. But the majority of people are actually infected probably by their own family in their own houses.
Yeah, gosh. So really wash your hands very, very, in fact, have a shower every time you come in and change your clothes, which is what I'm doing after I've done my COVID marshalling shifts. Andy, you were facilitating another group. Do you want to give us a question from your group?
Yeah, it was a question for Dominic. We were just a bit puzzled, the London v Blackburn with Darwin situation, because nobody uses the buses, the trains in Lancashire on the whole. They're very, very sparse, whereas in London, they're crammed solid. There's millions and millions every single day. So there seemed to be a paradox there, Dominic.
I think you're right, Andy. I mean, Sakti might have a comment on this. I mean, what we know is the London, if you look at the way in which the different waves of COVID peaked and then fell from the peak, what you see is London in particular goes up very quickly, goes higher than Lancashire's ever been. So some of the London local authority areas were getting a rate of 1,600 per 100,000 in early January. Now, Lancashire, even though it's got higher cumulative cases, never got anywhere near that. But they go up faster and come down faster. I'm not sure we know exactly why. I think it could be to do with this slower, we get maybe we're getting a smaller number of first cases, the index case, but this issue of household transmission means that we then get much larger numbers. Because people in London, yes, they commute more, they're more exposed through contact, so you're going to get more first cases in a sense, but they probably have bigger houses, less people per house on average, and their risk of that secondary effect of household transmission is, I suspect, less than ours.
Yeah,
but we're not absolutely sure, and it's a really good question. And then many people were saying, when we were getting higher rates towards the beginning of September, when it really took off, the second wave really took off, people were saying, why on earth isn't London doing this?
Yeah, okay. And probably time for one more from the groups. Charu, I don't know, does your group have a question to bring back? You're on mute.
Yes, thank you, Peter. I think the group, we were just getting going in our conversations about it. And I think they really came back with a comment more than a question. They were seeking for clarity of communication with simple messaging and not to create false expectations that sadly cannot be met, like the issue around Christmas and stuff like that. So it was very much around that.
Yeah, which I think we'll probably pick up in our third session, which is around public communication of health messages. I know Annabelle in our group, who social prescriber, was talking about the difference between communicating to more affluent, better educated groups and less so. So the need for tailored messaging, which I say we'll come on to in the third session, but I think we'll move on, if we may. You can continue to use the chat to ask questions, and and hopefully some of our experts will try and answer those in the chat, multitasking as we go. But moving on now to think about the vaccination, and praise the Lord for, you know, the fantastic work that has been done to bring vaccines onto the market so quickly, and full marks for all the elderly in Lancashire for dutifully trooping through the lobbies, even if they had to wait for more than 2 hours outside Blackburn Cathedral. I was there on Saturday morning. No one complained. It was amazing. So I've got Abdul Razak, public health consultant, and Imam Khalid from Preston, who are going to just talk briefly on this one about vaccines, briefly how they work, why are people hesitant, and why do they not need to be hesitant? So Abdul, do you want to go first on that one?
Yeah, thanks very much, Peter, really. And assalamu alaikum, everyone, really, and peace be upon you all. So basically, as Peter has introduced, really, I'm working with Sathi and Dom on the COVID response at Lancashire County Council and across the LRF area. I'm just going to basically describe, really, and bring Imam Khalid in to actually then, obviously, I'll touch on vaccine hesitancy, but I'll cover the major 2 points, really, around what is a vaccine, really, and clearly what's within these current vaccines around COVID. So a vaccine clearly is, elicits an immune response, really, producing antibodies, which actually enable the body to actually recognize the virus, really, to enable for it to actually then almost create a memory into simple language, really, and then obviously mount that actual immune response in terms of those antibodies, which clearly are able then to attack the virus and actually almost kind of neutralize it, really, and actually reduce the severity of the actual disease. It's obviously the science of that really is actually slightly more complicated, but in plain language, that's how vaccines actually work. They actually create that immune response. They create that memory. We have our flu jab every single year because of the strains that are circulating, usually within the Southern Hemisphere. And then obviously then they come and we use those strains through the World Health Organization to inform our UK-based kind of vaccination program. So in terms of that, those are the simple elements, really, of vaccination. In terms of key principles, it enables, but the issue really with COVID is that the world has no immunity. And that's really where it's different to flu in that sense, really, clearly, in terms of no one on the planet, really, other than the members and global citizens who've actually been vaccinated, really have any level of protection against COVID. And because it was a novel virus, not seen really within the human population before, and therefore we're seeing the impact that is actually posing. In terms of the aspect, really, what's within these vaccines. So basically, currently there are there are three. Let me start, really. There are three vaccines which have been approved by regulators, and the regulator is the Medicines, Health and Regulatory Authority, the MHRA. So the first vaccine that was actually approved was the Pfizer-BioNTech vaccine. The Pfizer-BioNTech vaccine is an mRNA vaccine. It's a new technology, not new really in the sense absolutely new, because they've actually been doing a lot of work around cancer treatments using this, but they've adapted that technology to actually then around the COVID fight. And basically it's gone through, so basically all vaccines that are actually approved need to go through phase 1, 2 and 3 clinical trials, including within humans. And phase 3 is that. So we've had thousands of volunteers come forward within clinical trials in the UK and abroad, overseas, globally, and using those trials, really, that those studies have actually now been published, and those are actually then assessed by the regulators to assess the safety and efficacy of the actual vaccines themselves. So basically, so the first one was the Pfizer-BioNTech, which is a European, German kind of Astrazeneca collaboration. The second vaccine really is the UK-based vaccine, which is the Astrazeneca Oxford vaccine. This is not an mRNA vaccine. This is an adenoviral vaccine. used really from from fragments really from basically based upon chimpanzee type research. And basically, just to say, really, there's no live virus in any of these vaccines. So basically, the AstraZeneca Oxford vaccine clearly was approved as well. And the third vaccine that's actually been approved really is the Moderna vaccine, which is a US vaccine, but that is not currently in use in the UK. That will only be available in the spring. So the only two vaccines that are actually available at the moment, which are currently used, is the Pfizer vaccine, which is being used really within the program for healthcare and care staff, and both these vaccines are a 2-dose program. Although nationally, basically at the moment, the national policy decision by the chief medical officers was that it'd be better to actually vaccinate everyone as fast as possible with 1 dose, rather than actually then do only partial population with 2 doses. And that clearly is what we are rolling out. There is a committee called the Joint Committee for Vaccination and Immunization, which basically is a Department of Health body of group of scientists and experts. They make recommendations to government on prioritization around who should be vaccinated. And currently there are 9 groups, and those that you can actually see behind me in terms of my background. And clearly we're in the process of actually vaccinating the first 4 priority groups. Those are care home staff and residents, healthcare staff, inpatients, over 80s, over 75s, over 70s, and the clinical extremely vulnerable. And government actually set a target to vaccinate 15 million within those cohorts by mid-February. And clearly, we're nationally, the national figure is we're above 10 million. So within the next kind of few days, really 10 days, we may get close or exceed that level of ambition. And then clearly we will actually then roll out into the other priority groups.
Yeah.
So basically, in a nutshell, really, that's where we are in terms of vaccine hesitancy. Before we actually move on to Khaled, really, some emerging themes really from the national data around the vaccination program as well, really. So there's huge variation amongst the various groups. There's almost everywhere in England we have got significant inequality around the uptake. There's poorer coverage in deprived areas, and there's significant variation between the main population groups, and there's poorer coverage in certain specific areas. Around the ethnicity issue, it's not explained by deprivation, and we've got a particular issue in terms of hesitancy amongst the Black, Pakistani and Bangladeshi ethnic groups. And now at that point, I'll pass on to Khaled, who can explain some of the hesitancy issues. Thank you.
All right, thanks very much for that quick tour of vaccines and the immune response, Abdul. Yes. Okay, Khaled, do you want to just pick up from there and move us through a little bit more on reasons why people are hesitant and reassurances that can be given?
Yeah, so I'm just going to come back onto Dominic's first presentation, and immediately my mind went into overdrive, because if we're going to get some level of news coverage in the next 24-48 hours about the mutation and the current vaccine not being as effective as it was previously mentioned, then I think the conspiracy theorists and so forth are just going to seize the opportunity and blast the message that these vaccines aren't going to do any good, because the amount of vaccines you'll have to take is going to be endless because of the mutations. So that's just one example of why there is some level of hesitancy, because unfortunately, as Dominic said, there is no pathway. We don't know how many times this virus is going to mutate. We don't know how many times the vaccination will have to be adjusted. And these are just some of the myths that we've got within the communities. Having said that, especially within the first 2-3 categories, I've seen that the uptake within the community has been pretty good. People have been really trying to find out when they're going to get vaccinated. They want to know, where they can go, more information. And what I've seen from my experience is that because I get the opportunity to go to the hospital, and people from within the community, they get to listen to the experiences of patients, of not just the elderly. Currently in Royal Preston Hospital, we've got people from Muslim communities in the ICU from all different ages. We had a 25-year-old, unfortunately, who passed away on Saturday. Then a 34-year-old who was from Blackburn, but in Royal Preston Hospital, who sadly passed away on Monday. When these messages go out in the community, I think they are realizing that it's not just the elderly who are vulnerable. And it's not that we're capitalizing on these patients, but it's important that the reality of the hospital is put forward to the community, so that these myths about only the elderly being vulnerable and only they should be prioritized, it's important that these key messages are out there within the community, so that the uptake of vaccination is far greater than what we are currently seeing.
Okay, thanks, Khaled. That probably brings us to a point where let's go into breakout rooms.
I can interrupt if I may. It's Anton.
Go on, Anton.
It was reiterated again, it really came out of the first session that one of the things that's been highlighted, and even in the rollout of the vaccine, is the disparity, the socio-economic disparity, and are we paying the price of lack of investment in the North and the Northwest, which has itself then contributed to the level of exposure. And now in the rollout of vaccines, is there still a lack of prioritizing in the North and Northwest? Because if this now finally is not addressed nationally, then we will just see a continuing deterioration of health and well-being in this part of the country.
Yeah. So, well, we hope and pray that one of the outcomes of this is that the structural inequalities that many of us have known about, that this will be a further, lever in addressing those. Abdul, was there anything from your group that you'd like to share, or to pick up on that particular issue of side effects? And I guess it's inevitable that there are side effects, but how does one give reassurance so that somebody won't be put off having the vaccination by the fact that they might get a side effect? Abdul?
Yeah, thank you. Thanks, Peter. One of the issues clearly from our group, before I come to side effects, really was the main message really was influence the people that we can influence, and clearly, we can't control social media. What we can do is actually try to actually reach those within our population and our residents really, and our congregations who are able to, who have the ability to influence others in a positive way. So that's within our gift and control. But also actually we know really that there are certain parts of the population which are just kind of doubtful. Basically they need a bit more convincing. So we need to target those really than the ones who are adamant that they just simply not want to take the vaccine. We need to keep working with those individuals really, but ultimately we may not turn them around. So we need to obviously do the best that we can really in terms of the Community Champions funding. And clearly there's at least 1.6 million around Lancashire County Council area across the 6 districts, but Blackpool and Blackburn and Darwen have also been awarded some government money in this regard to actually tackle vaccine hesitancy and increase uptake. And local authorities have a great responsibility in that by working alongside faith organisations and community organisations in that regard. Coming back to side effects, really, this is something really which is becoming far more prominent. The issue around this really is that there is some national advice on this. There's on the gov.uk website, there is something called there's a page which is quite detailed, which includes side effects. It's called, I can send the link or put it into the chat. It's what to expect after your COVID vaccination, which clearly articulates exactly what the side effects may actually then be. The common side effects, these are transient temporary side effects, which may last 2 to 3 days maximum. And these are obviously a fever, a headache, kind of chills, shivers, and basically you may get a bit of nausea, and some people clearly may actually feel rough, for a few days. But it's better, clearly, obviously, in terms of communication, there's also some national videos now by occupational health clinicians who are actually describing this There's more work really by others such as Dr. Hillary in this is great, Good Morning Britain and all that kind of stuff. So there's more and more prominence really to come forward for the vaccine. Some part, a small percentage of the population will actually get some of these common side effects, but it's nothing to worry about. And basically, this is your own body clearly, producing that immune response.
Yes.
But it's unpleasant. It's unpleasant. For a very short while, but then it offers you that protection in terms of, and that's really the positive kind of end to the actual messaging.
Yeah.
Thank you.
Thanks, Abdul. Yeah, Khalid, I don't know if there was anything from your group. I'm conscious that you're in quite a unique position in your role, sort of straddling between the your role as an imam in a mosque and also your medical colleagues at the hospital. And anything you'd like to add, Khalid, around that sort of reassurance of, well, let's take Amy from the Jewish community raised the fact that people in some in her community are saying it's the will of God, it's the will of Allah, I'm not going to do anything. How do we counter that? For example, could you just sort of come back to us for a moment, Khalid?
I think combating the concept of will of God is very easy from a faith perspective, because if that was the case, then no other medication should be taken as well. The vaccine is no different to any other medication. And believe me, if someone was to see anyone struggling with breathing difficulties, then the first thing that they would want is oxygen and regret the fact that they did not get vaccinated. The reality, and there's no time for us to give a soft approach on this topic. It needs to be hard hitting. People need to know what the reality on the ground is as well. And with Ramadan and everything coming in, already positive messaging is taking place within the mosque. And I think, the uptake is going to go significantly higher. What I would like to see, and, I'm going to seize the opportunity because we've got professors on the webinar, is some level of data to give us an indication if people are not taking up the vaccination offer, especially from within ethnic minorities. And if we can possibly break that down further with Asian Pakistani communities, and I know it might be more difficult with faith communities as well, so that the messaging can be targeted more precisely rather than just a generic message that's basically going out within our communities at the moment. So I'm not sure if that data is available. I know like maybe 90% of the 75 plus have been vaccinated. How many did not take up the offer, so that we can have maybe a focus group to understand in more depth what's the reason behind them not taking up the offers.
Okay.
Peter, if I can come in really just to explain really, the data around uptake is has been slow to arrive really with Sathney, Dom and Arif really as directors of public health. We've got some access to data in terms of high level data, in terms of early signals, but the granular information that we actually need to actually make informed decisions is still not with us. So we can make some level of understanding really around uptake, and we're only partially way through. But the headlines clearly is from national work, we know that certain communities, even within the Asian communities, but we don't know whether that is the same for for Preston or for Blackburn and Darwin in terms of absolute granular information. So we're waiting for that granular information at the moment.
Okay, thanks, Abdul. I think that's really encouraging, and thank you so much, Khalid, for that very clear stance from you as an imam, that these messages have to be hard hitting at this point in time, and there's clearly an important role for faith leaders in all our faith communities there to be informed and to be communicators. So, talking of communicators, I'll lead seamlessly on to our third section, which is around communication of health messages. The directors of public health have really come into their own in this last few months. So, Dr. Sathney, Dominic and Abdul are now household names and well recognized. So over to you, Dr. Sakthi. Thanks so much again for your time. Just something around why do, just perhaps not getting into too much specifics, but what is it that makes a public health message? What makes one succeed? What makes one fail? And then Reverend Susan is going to just give us something again in that sort of wider context. So over to you, Sakthi. Thank you.
Thank you, and good morning, all. It's a pleasure to be with you all again. When we were conceiving this discussion, we had a wide-ranging debate and a discourse about how do we approach this. There is clearly, well, this is a forum of faiths, so where do we start? And how does religion, science, faith, and nature all, how can it all come together in this pandemic to get the message across, so to speak? So I'm going to briefly touch on some of the history, if you will, as I understand it, about how the confluence of religion, the philosophers, and the science actually emerged, which was basically questioning everything, as we all understand, with the rational reason or reasoning to understand what's going on, and trying to demonstrate that as humans we have knowledge, and why we should have knowledge is to understand things around us, and whatever we are trying to achieve as an effect, we must have knowledge. That's so if you trace back to ancient philosophy and whatever has happened before. And then one of my favorite ones is to relate to my own culture, and there's a rich tradition of literature in all languages and in all cultures and all faiths. And my favorite one, just on this topic about health and public health messaging and what we do, is an ancient poet called Thiruvalluvar. He's written a couplet which I don't mind sharing with you at this juncture, and I'll read it. It's called, but it goes like this: Noi nadi, noi mudal nadi, adutanikum, vai nadi vaipachayal. It's in Tamil. It means, let the physician inquire into the nature of the disease and its cause and the method to cure, and treat it faithfully according to the currently prevailing rules, so to speak. And I wanted to directly apply that to the current situation in terms of understanding the pandemic, understanding the virus and what actually causes it. And if you put that in the current modern definition of health, health is a state of complete physical, social, and mental well-being, and it's not really just absence of disease or infirmity. Science has progressed so far in terms of the physical causes of ill health, but it is still very elusive when you come to mental state and social well-being. Inevitably, there is an explanatory gap. Even if you are a hard, fast follower of a particular faith, or a hardcore scientist, or just a naturalist trying to explain God, nature, and force, there comes an explanatory gap in terms of how do we explain mental state, mind, and some call it consciousness. This is very important because that directly links to how we understand the world around us, and that really is directly associated with our own behaviors. So if we are to address or to promote any particular messages to our public in order to change behaviors, not only do we need to understand the disease and its root causes and how it spreads, but we also need to understand the receivers of the message and how they understand their worldview, so to speak, so that we can have shared language, whether that's God's own language or something that we've created is up to us to do what we are here to do. That means taking this a bit further in this current pandemic, to get the message across is not simply about having just the message. We also need to understand and be very careful about the messengers, as well as the medium in which the messages are reaching people. I mean, social media is very prevalent these days, but this isn't the only media, and quite often social media can have disinformation and misinformation. So the message, the medium, and the messengers are all important when it comes to public health messaging. And just moving that a bit further, what actually, there has been quite a lot of research, and I'm going to just give the concentrated summary of that in terms of how do we be successful in getting the public health messages across. And the first and foremost thing is to be honest and transparent in what we're seeing, and that inevitably will be felt, even if it's not seen by members of the public, about the messengers and the medium too. And we have seen throughout that, well, certainly in my experience, just being transparent, plain talking, and being honest about what you're seeing and saying that to the public actually has helped. And it has helped cut through all sorts of scientific jargons. So that's number one. The second one really is, it's okay to tell a complicated, convoluted story, but whatever messages we are giving out, they need to be simple to follow. Even if it's a very complicated science behind that, if we don't break it down into simple to follow messages, people will, to start with, will find it hard to understand, let alone actually adopt the behavior. And ultimately, these messages are aimed at changing behavior, whether that is hand washing, wearing masks, or maintaining the distance and getting a test. And any of these are ultimately an action that we need to do, not just at the thought or the words level. The third one, which is the fundamental one, is to remove barriers. It's okay to ask people to stay at home for 10 days, but it will not have any effect if we are not addressing some of the more immediate barriers. It may be financial barriers, it may be duty to care for someone. And these things are fundamental to any messaging. And often you can be a glass half full or a glass half empty communicator. And the thing that really has held true in my experience is, if you follow, be honest and transparent, keep the messages simple and be able to follow, and try to be at least appreciative of the barriers, remaining hopeful, which we have discussed in this forum in the past, and a subject matter for future as well, is very, very important. And not to create more despair, but to remain hopeful, because only by remaining hopeful we can make progress in any aspect of life. And this takes me right back to religion. And having studied and tried to understand many faiths in my time so far, there are two common things in every faith and religion. One is, well, both of them are aimed at God realization in a way. One is worship, which is understanding God, and scientists may want to call it consciousness. In my opinion, I think these are different labels which we might need to unpack later, but that's one common factor of every faith, which is worship. The second is virtuous actions or moral actions, mainly actions that doesn't harm oneself or others, and wherever possible, remove the suffering of others, and being that charitable, having that charitable mindset. So worship is an internal activity. Although we may have statues or not have statues, it involves inward travel, and virtuous way of action is doing something. So if you put that together, we have a package for keeping ourselves safe and healthy and ultimately peace. And so these three factors are really important in my practice so far. I'll leave that way to Susan.
Thanks for that. Thanks for that nice encapsulation there of what hope based on internal connection with the divine in worship and external expression through service or action. I think that links quite nicely, Susan, to your experience, Reverend Susan. I know you've been, you've worked in palliative care, and you're also training, or you are a deacon in the Church of England and training for the ministry. So hand over to you, Susan.
Thank you very much, and thank you for asking me to talk today. As we mentioned, I kind of straddled two different disciplines. For 30 years, I was a medic, a doctor, a consultant in palliative medicine, and then recently was ordained priest in the Church of England. So I kind of have two aspects to things. I think it's very important for me to say, first of all, that, I went back into the NHS during the first wave in April and May, working back in Blackpool. So obviously had that experience of kind of being part of that frontline workforce. This time I'm in the front line of active parish ministry, and all that means in terms of supporting 5 local rural communities. But I'm not an expert, and I wouldn't claim to be one. And I'm sure, and other people are far more knowledgeable in these areas. But I wanted just to share some thoughts with you. I mean, this global pandemic is like no other pandemic that's ever played out in the past, from Martin Luther onwards, because it's been played out in social media, on 24-hour news channels, with their requirements for sound bites and instant answers and clear statements of cause and effect. And I think just from this morning, we've discovered that isn't how it is. It isn't, do this and this will happen. It's not that, if you go to the shops, you're inevitably going to get COVID, but you might get it. And it's very hard to convey those kind of messages in our 24-hour news hungry age. I think the other thing, though, is that this is an opportunity for us to recognise that both medicine and theology have a real role to play in trying exploring and understanding what is a really complex interaction between our bodies and the risk of infection, our mind and what we think we know and what we want to do and what we choose to do, and our spirits, what makes us who we are and also makes us either hopeful or not hopeful. And there's a huge opportunity here for us to continue to build on those links that have definitely come more to the fore during this pandemic. I think one of the things for me, having been both a medic and now a priest, is that medicine and faith talk about different approaches to the same process, which is that process of making sense of the world, and particularly that process of understanding dis-ease rather than disease. And obviously medicine concentrates very much on studying how our bodily systems go wrong and what we do to fix them. Whereas theology, as Sakti has so beautifully illustrated, is all about what is our lived experience of when our bodies go wrong, and how do those two things interact with each other. And it's a beautiful and complex and fascinating process, which is what we're all grappling with this pandemic and messaging about the pandemic. But for me, it is about the thing I think that I want to just concentrate on is actually about the listening bit, the bit that actually says we need to just pause a little bit and listen to each other. And I'm just going to be very cheeky and quote from 3 different thinkers to highlight how that listening has to be an important part of what we do and shape, and that listening to shape our health messages, both nationally in Lancashire, but also very locally, because I think all of us in faith communities have a real duty to be listening, and then to also be part of that messaging about what is important. So the first person I wanted to briefly talk about is Rita Sharon, who is one of the founders of an approach to healthcare called narrative medicine. And that arose out of her studies about the barriers to effective communication between a doctor and their patient, and getting the patient to work with the doctor, particularly around life-limiting illnesses. And she very much highlights that the lived experience of an illness is as important as the actual pathophysiological process that's going on within the body that the doctor's interested in. And that actually doctors need, and doctors and all healthcare workers, and I would argue priests, also need to recognise this. And what she wrote is this: scientifically competent medicine alone cannot help a patient grapple with the loss of health or finding meaning in suffering. Along with scientific ability, physicians need the ability to listen to the narratives of the patient, grasp and honour their meanings, and be moved to act on the patient's behalf. And I think that's something of what we are needing to do now, which is actually grasp the stories and understand not just the physical reality of those stories, but the meaning behind them, of what both the patient, but also their family and their community are understanding by that. And if we do that, then that will also help us to influence the messages that we give. And I think one of the things that we have to recognize is that there are other things outside health that influence what people think. Things like shame. You know, this is an infection. Infections are dirty. Therefore, I'm not going to talk about it. There's all those issues about guilt. Did I give it to my grandmother? Did I give it to my son or my daughter? And the blame. It must be someone's fault. Therefore, I need to find who it is I'm going to blame. So it's very much part of the lived experience. And the only other thing I was going to share is that actually our stories are really important. And I think our stories can be part of those healthcare messages, as long as we're clear about them, their stories are clear about what the actions are from them. And I just wanted to share something from the former Chief Rabbi Jonathan Sacks, who in his book, The Dignity of Difference, wrote this: human beings inherently seek to understand their place in the universe, and that's what all faiths are about. And within each of us, there's a drive to know where we have come from, where we're going to, and of what narratives we're part of. So we form families, communities, and societies. There's a drive to tell stories and talk about ourselves. The drive to search for meaning is particularly pressing when our health is under threat. And so I think each health community also needs to tell their story, to think about what makes sense to them about this pandemic, and to use those stories as well as the public health messaging to influence and encourage people to, I was going to say do the right thing. That's probably not the right way to put that, but to actually just say, listen to each other, but share your stories. And in sharing your stories, find that common approach to acting appropriately.
Brilliant. Thank you, Susan. And I think you added nicely another M to Sackth's 3 M's of message, medium, and messenger. You've added the sort of the overall thing of meaning. Whether it's possible for that all to be incorporated in a package of a very simple public health message, I don't know, but it's important for us as responsible people to be mindful of the importance of that. I'm going to send us into our final breakout rooms now.
Yeah, thank you very much, and it's been a real privilege to be in the breakout groups and to hear the amazing things that are already going on. Everyone in that group certainly felt that the information that they're receiving was extremely helpful, a good clear message, good data. Often at times that message is confused or it's incomplete, so certainly it's been really helpful to have just direct data that's been very helpful to guide our discussion. I think in the summing up, I just want to put it out as a question for us all. This is dominated by dominantly a faith community, a cohesion exercise, and it's this question: how do the faith communities, how may the faith communities work together? They're often seen as disparate, and they believe this, they believe that, and they're not together. There is an opportunity now, and we've seen lovely examples. I was hearing good stuff coming out of Blackburn and Darwin, and good stuff coming out of Burnley, building bridges in Burnley. So here's the question: how may the faith communities work together to rebuild hope in a post-COVID community? There was a lovely illustration that came to mind. Someone mentioned the Second World War. After the Blitz in London, people are kicking over the traces and pulling up the rubble, and yet in the rubble, they're finding life, they're finding hope. We're going to come out of this situation and it will feel like that. Lives have been destroyed, businesses have been destroyed, homes have been destroyed, and yet in there, kicking over the traces and pulling life and hope out of the rubble, the faith communities. So the question that I want to leave us all with is, how may we, as a diverse group across all the faith communities, contribute to the rebuilding of hope in a post-COVID community? Thank you.
Just to talk around that a little bit more, around messaging, communication, maybe think of those 3 M's that Sakthi talked about, and message, medium, messengers. Susan's point about meaning and stories. And then when we come back, Anton's going to facilitate our final discussion and close for us. So
can I have a go at that one? Yeah. I think one of the things that faith communities particularly have is an ability to mobilize, 2,000 years of wisdom in a way that probably hasn't been maximized yet. So, I'm a practicing Catholic, but one of the Catholic Christian, I think that if I look in my own tradition, in scripture, for instance, there is an enormous wealth of knowledge and experience around the act of lamentation. And lamentation, of course, there's the book of Lamentations and there is the book of Psalms, which is basically the ordinary people moaning at God and moaning at each other and moaning at their civic governments and suggesting solutions. And one of the functions of lamentation is really to express grief collectively. And of course, one of the reasons why hope can be difficult is in a situation where grief is present. If you haven't moved through that grief appropriately, if you've been rushed through, or if you've been told to be quiet or just grin and bear it, or it can't be helped, everyone has to suffer it. But if the grief isn't expressed, then some of that move towards a more hopeful response can be stifled. And of course, one of the perhaps broader impacts of this virus is not just the mortality, the deaths, but is going to be the mental health impact for everybody. And actually, I think in all our traditions, we probably have a wealth of wisdom and knowledge that we haven't quite made visible to the rest of society, because actually that process in the Christian and Jewish and other traditions of lamentation was evolved probably for very functional reasons. And we're not doing enough of it, I think. And actually it could be really critically important for our collective mental health. And particularly lamentation was used in the Psalms for holding people to account, which is the other bit that people feel. People feel cross that some things should have been done and weren't, and they want to say so. Or they want people who are responsible, including me and Sakthi and others, to explain themselves. And that is also critical, because it goes back to trust. And there's a number of prerequisites for hope and for moving on. And we are in danger a little bit of missing some of the wisdom we already have, I think, in faith communities.
Yeah, that's wise words, Dominic. wise words. And just to close, perhaps, is there something? I think the issue of trust is one that has arisen. I heard it in our group, and maybe faith communities or faith leaders are still perhaps figures who are trusted, who are not political, who are not local authority, don't have a political axe to grind. So maybe faith leaders could be adopting a higher profile here in being involved in messaging. And perhaps this is another area where partnership between faith, health, and local authority could work together in terms of public health messaging.
Indeed. So, and we have news of initiative, Peter, that I shared with you called the As One Initiative. It's a post-COVID partnership proposal. And after this meeting, I'll share with Peter the details of this, but it's an opportunity for faith communities to work with the civic communities and the health authorities. I'll just give you one sentence out of the notes that I've got of the As One. It's a national initiative. It says this: many people will emerge having experienced profound anxiety, grief, loneliness, and trauma. How might they be met with a warm embrace rather than cool indifference? People will need kindness and a sense of being as one in supportive community more than ever. And so we'll be sharing with you details of this As One initiative. It crosses all faiths, cultures, civic authorities, health services. It's a banner campaign, but it also is talking about helping to rebuild community just in your own street, as well as the village, the town, the city. And we will share details of that national initiative that's coming to us soon. Thank you.
Just if I may make a quick comment, or just as a follow-up on that, I think there is definitely a theme here about commonalities across the faiths. And like Dom was saying, more than 2,000 years of wisdom, dare I say, but a dimension on love and compassion. We know that all faiths and all religions have love and compassion inbuilt in that, but there is also emerging scientific evidence about you taking care of yourself and others. It can have neurological changes, which ultimately improves everyone's outlook and excellence. So I think we collectively have something here about faith and science communities working together to rediscover love and compassion post-COVID, which goes straight into the emotional, mental, and social well-being, which is, again, the complete definition of health.
Yeah. Okay. Thank you for that, Sakthi. I think we have extended, but we should finish now. But I hope there's been some useful information given there, some useful sharing. You've talked with people who have like mind, perhaps, even though we're physically separated, we are able to meet together like this and share our experiences and make plans to address issues, and to do that in partnership. So I personally am encouraged that there's more opportunities. I'm hearing more opportunities for faith groups to work with public health and local authority for the common good. And there was some good theology in there as well, I think. So thank you very much, everybody. We, as the Lancashire Forum of Faiths, with churches together in Lancashire and the Lancashire Resilience Forum, we will be doing more of this sort of subject that crosses over, but is topical as well. So thanks very much, everybody. Take care, and see you soon.